Welcome to the Deep Dive. Today we're jumping into the very latest clinical thinking on atrial fibrillation AF as you know it. We're looking at the professional guidelines updated just this past December 2024.
That's right. And there are some, well, pretty significant shifts in how we're being advised to approach it.
Before we get into those shifts, maybe just a quick refresher for everyone listening. What exactly is atrial fibrillation? Keep it simple for us.
Sure. Basically, AF is a heart rhythm problem. The heart's upper chambers, the atria, they stop beating in a coordinated way. Instead, they just sort of quiver chaotically.
Like periphery, okay.
Yeah, and this chaotic signal gets sent down to the lower chambers, the ventricles. So the result is usually an irregular and often quite fast heartbeat.
Okay, irregular and fast. Sounds unpleasant, but why is this such a big focus? What's the scale we're talking about here?
Oh, the scale is huge. It is hands down the most common sustained heart rhythm disorder we see in adults.
Most common. Wow.
Yeah. And the prevalence, it just skyrockets with age. If you look at people aged, say, 25 to 45, it's less than 0.1%. Tiny.
Almost negligible.
Right. But then you look at folks 85 and older, and it jumps to nearly 16%. 16%. So, well over half of all AF patients are 75 or older. It's really a condition linked heavily to aging.
16% in the over 85s. That's a lot.
It is. And probably the single biggest message, the kind of philosophical shift in these new guidelines is this. AF shouldn't be seen as just like an isolated electrical glitch in the heart.
Okay.
It's almost always a sign, a symptom, really, of other things going on, other cardiovascular issues or sometimes even non-cardiovascular problems. It's a marker for underlying health issues.
So stop thinking wiring problems, start thinking systemic alarm bell. I like that reframing.
Exactly. It's the smoke, indicating there's likely a fire somewhere else in the system.
So if it's systemic, how do these guidelines change how we should be, looking for it or screening for it?
Well, that leads right into one of the key practical updates. There's this new recommendation for what they're calling low threshold heart rhythm checks.
Low threshold checks, meaning?
Meaning if you have a patient who's 75 or older and they come in complaining about something nonspecific, just feeling generally unwell, tired, maybe a bit dizzy.
Vague stuff.
Exactly, vague stuff. The guideline says you should check their pulse rhythm right then and there. Palpate the pulse.
Ah, okay. So just feeling the pulse for irregularity, even if they aren't complaining about their heart specifically.
Precisely. It makes sense, right? You're already seeing the patient. It's low-tech, opportunistic screening. Which brings us nicely to that first big topic, diagnosis and screening.
Okay, so we're talking simple pulse checks. How good is just feeling the pulse, really? And what's needed for the actual official diagnosis?
Well, the official diagnosis standard hasn't really changed. You still need proof. That means either a standard 12-lead ECG showing AF or a single-lead ECG tracing, like from a rhythm strip or a monitor, that lasts for at least 30 seconds straight.
30 seconds minimum. Got it.
But the interesting part is how effective that simple pulse check can be for detection. The recommendation is basically whenever you measure someone's blood pressure, you should also feel their pulse for rhythm, even if they feel fine.
Opportunistic screening, like you said.
Exactly. And the data backs it up. Pulse palpation alone is actually pretty sensitive for picking up AF. We're talking sensitivities usually between 87% and 97%.
Right. 87 to 97% sensitivity just from feeling the pulse? That's really high. So why the insistence on the 30-second ECG then? If the pulse check is that good, isn't the ECG requirement a bit much?
That's a fair question. It comes down to the difference between detecting an irregularity and diagnosing AF specifically.
Ah, okay. Detection versus diagnosis.
Right. The pulse check flags a potential problem that raises suspicion. But you need the ECG to confirm what that irregularity is. Is it definitely AF? Or could it be something else, another type of arrhythmia? Plus, you need that documented ECG for, the medical record, for coding, and to make firm decisions about treatment, like specific drugs or procedures.
Okay, that makes sense. The pulse check is the signal, the ECG provides the certainty and the documentation.
Precisely.
So, given that the signal is relatively easy to pick up opportunistically, why aren't the guidelines pushing for systematic mass screening? To checking everyone regularly, regardless of why they came in.
Yeah, that's a really big debate. But the guidelines, based on the current evidence, advise against it.
Why not? Seems logical.
Well, there just isn't enough solid proof yet that a huge systematic screening campaign actually leads to better overall health outcomes compared to the standard care we're already providing, like that opportunistic pulse check. And then you have the potential downsides. Risk of overtreating maybe very brief, insignificant episodes found by chance. patient anxiety from potential false positives, and of course the cost and resources needed for all the follow-up tests. Right now, those potential harms seem to outweigh the unproven benefits of mass screening.
Okay, fair enough. Evidence isn't there yet. Now, what about all the tech? We've got smartwatches, phone apps, even some home blood pressure cuffs claiming AF detection. Where do they fit in?
They're definitely part of the picture now, and they can be remarkably good at detection. Some have sensitivities up in the high 90s, even 99%.
Wow.
So they're great tools for flagging an irregular rhythm that needs looking into. But, and this is a crucial point, the guidelines stress these devices are not diagnostic tools by themselves.
Still need the official ECG.
Still need that medically validated 30-second minimum ECG for the actual diagnosis. If your watch flags something, it means go get it checked properly. And the guidelines also say, those little non-diagnostic alerts from wearables, especially if they're super short recordings, don't necessarily need a big immediate workup unless the person's having symptoms or their pulse feels irregular when checked in clinic.
Right, makes sense. Okay, let's shift gears. We found the AF. Now, what about the biggest danger? Preventing stroke. That seems to be the main driver for treatment, isn't it?
Absolutely. It's the dominant concern. Thromboembolism, mostly leading to stroke or cerebral infarction. For an AF patient who should be on anticoagulation but isn't, their risk of stroke is, on average, 5 times higher than someone without AF.
5 times?
5 times. That's a stark number. And I assume that that risk isn't the same for everyone with AF.
No, definitely not. It varies hugely, which is why we use risk stratification tools. The standard one is the CHA2DS2 VASC score.
Right. CHA2DS2 VASC. Can you quickly break down what factors go into that score?
Sure. It's basically a checklist of risk factors, and some weigh more heavily than others. The biggest ones, worth 2 points each, are being 75 years or older or having a history of a previous stroke, TIA, or any other systemic embolism.
Okay, age 75 plus and prior stroke AA are the heavy hitters.
Exactly. Then you get 1 point each for several other common conditions: documented heart failure, high blood pressure, hypertension, diabetes, vascular disease, which could mean a past heart attack, peripheral artery disease, that sort of thing.
Got it. Also, being age 65 to 74 gets 1 point. And being female also gets 1 point in this scoring system. You add them all up, maximum score is 9.
Okay, so we calculate the score. What number actually triggers saying, okay, you need anticoagulation?
The guidelines are quite specific based on the data. For women, a score of 3 or more means oral anticoagulants are recommended. For men, it's a score of 2 or more.
3 for women, 2 for men. Clear thresholds. Now, once we decide on anticoagulation, the guidelines strongly prefer OACs, oral anticoagulants, over older options like aspirin, right? You mentioned platelet aggregation inhibitors, TARs.
Oh, absolutely. The difference in effectiveness is massive. OACs, whether the older vitamin K antagonists or the newer direct oral anticoagulants, reduce that stroke risk by about 65%.
65% reduction.
That's significant.
Hugely significant. Whereas TARs, like aspirin, they only reduce the risk by about 20%. It's just not enough protection for AF, and they still carry a bleeding risk. So the consensus is clear. TARs like aspirin are not considered useful for stroke prevention in AF. Okay, no aspirin for AF stroke prevention. Got it. Now, within the OACs, you mentioned the VKAs and the DOACs. This brings us to that second major update. The preference for DOACs for new patients starting therapy. Why the shift towards DOACs?
Yeah, this is a big one. The recommendation to prefer DOACs drugs like apixaban, rivaroxaban, edoxaban, dabigatran over the older VKAs like warfarin or cenokumarole for newly diagnosed patients needing anticoagulation comes down to a couple of things.
Okay.
First, efficacy. DOACs are at least as good as VKAs and might even be slightly more effective in preventing stroke or systemic embolism based on large trials. Second, and maybe more importantly, safety.
Safety. How so?
Particularly regarding bleeding risk. While all anticoagulants increase bleeding risk, DOACs seem to have a lower risk of the most dangerous type of bleeding, intracranial hemorrhage, bleeding inside the skull. That's a major advantage.
Lower risk of brain bleeds. That's definitely compelling. And I guess they're easier to use too. No constant blood tests.
That's a convenience factor, yes. DOACs are generally taken as a fixed dose once or twice a day. VKAs require regular blood tests, INR monitoring, usually managed by a thrombosis service, to keep the dose in the right range, which can be quite burdensome for patients.
Okay, potentially slightly more effective, definitely safer regarding brain bleeds, and way more convenient. Sounds like a clear winner. What's the catch? Must be cost, right?
That's the trade-off, absolutely. DOACs are significantly more expensive than VKAs. We're talking, maybe 50 to 70 euro per month for a DOAC versus maybe just over €1 per month for the VKA drug itself, plus the cost associated with the monitoring service.
Wow, that's a massive price difference, order of magnitude.
It is. So while clinically preferred for new starts, the cost is a major factor in healthcare systems globally. It's a big policy discussion.
Understandable. One last really tough question on anticoagulation. The fragile elderly, someone who's, say, 90 years old, high risk of falls, maybe some cognitive issues, they'll have a high CHA2 DS2, just a fast score, but also a high bleeding risk. Do we still anticoagulate?
That is probably one of the hardest decisions in clinical practice. But the general consensus, reflected in the guidelines, is yes, even in the very elderly and frail, anticoagulation is usually still preferred over doing nothing.
Really? Even with the high fall and bleed risk?
Yes, because their stroke risk is often so high that the absolute benefit from preventing a devastating stroke still outweighs the absolute risk of a major bleed, even if that bleed risk is also elevated. But the decision needs extreme individualization. You have to weigh everything for risk, kidney function, patient preference, life expectancy, and the choice between a VKA and a DOAC in that specific patient needs very careful thought. It's not automatic.
Okay, so stroke prevention is paramount. Let's talk about pillar 2, managing the patient's symptoms day to day. This is often about controlling the heart rate, right? Rate control. What's the goal there now?
Right. The main goal of rate control is improving how the patient feels, reducing symptoms like palpitation, shortness of breath, maybe poor exercise tolerance. And the target for heart rate has actually become a bit more lenient.
More lenient. How so?
We used to aim for quite strict heart rate control, like under 80 beats per minute at rest. But studies have shown that a less strict target, generally aiming for a resting heart rate below 110 beats per minute, often provides similar long-term outcomes and symptom relief, but usually with fewer medications and side effects.
Okay, so aiming for under 110 at rest, that seems more achievable. How do clinicians pick the right drug to slow the heart rate down? Does it depend on other health problems?
Oh, absolutely. It depends critically on whether the patient has heart failure, specifically heart failure with signs of fluid overload.
Okay, so heart failure is the key differentiator.
It really is. If the patient does not have heart failure with fluid overload, the first choice is usually a beta blocker. Metoprolol is often preferred.
Beta blocker first line, no heart failure.
Right. Second choice would typically be a non-dihydropyridine calcium channel blocker, like diltiazem. Digoxin is usually third choice in this group, mainly because it doesn't control the heart rate very well when the person is active or exercising.
Okay, beta blocker, then calcium channel blocker, then digoxin if no heart failure. What if they do have heart failure with fluid overload?
Then the choices flip, and you have to be much more careful. In heart failure with fluid overload, digoxin actually becomes the first choice medication for rate control.
Digoxin first.
Interesting.
Yes, beta blockers can still be used, but they need to be started at low doses and increased very cautiously because they can sometimes worsen heart failure initially. But here's the critical warning. Those calcium channel blockers we mentioned, diltiazem and also verapamil, are generally contraindicated, meaning you should not use them in patients with heart failure and fluid overload.
Why not?
Because they can weaken the heart's pumping function, what we call a negative inotropic effect, which could make the heart failure worse. Big safety point there.
Got a huge difference based on heart failure status. That really drives home the point you made earlier about AF being systemic. Which brings us to pillar 3. Optimizing those other conditions, the comorbidities. What are the big ones we see with AF? The overlap is massive. Hypertension, high blood pressure, is seen in something like 62% of AF patients, diabetes in about 26%, and clinically diagnosed heart failure in around 23%.
Wow, those are high rates.
They are. So aggressively managing blood pressure, blood sugar, and heart failure symptoms is just fundamental to good AF care. And beyond those, tackling other modifiable risks is key too. Things like obesity, aiming for a BMI under 25 if possible, cutting back on excessive alcohol, and encouraging physical activity.
Makes sense. Manage the whole patient. Now, we hear a lot about rate control versus rhythm control, trying to actually get the heart back into a normal rhythm with things like cardioversion or ablation. How do those strategies compare long-term for the average patient?
This is another area where the evidence has been quite interesting. For many patients, especially older individuals or those with minimal symptoms, Just controlling the heart rate seems to result in comparable long-term outcomes in terms of things like mortality and stroke risk compared to actively trying to restore and maintain a normal rhythm.
So trying to force it back to normal isn't necessarily better long-term for everyone.
Not necessarily, especially when you consider the challenges of rhythm control. Electrical cardioversion, for instance, often doesn't last. Even with medications to help maintain normal rhythm afterwards, maybe only 30% to 50% of patients are still in normal rhythm a year later.
Only 30 to 50%. That's not great odds.
It's a challenge, which is why rhythm control strategies like cardioversion or the more invasive ablation procedures are usually reserved more for younger patients or those who have really persistent, debilitating symptoms despite good rate control. For many others, good rate control plus optimal management of everything else is the main goal.
This all points towards needing a really coordinated approach, doesn't it?
Exactly. And that's where the concept of integrated care comes in, which the guidelines strongly support. Sometimes it's framed as the ABC pathway. Yeah. A for anticoagulation and avoid stroke.
Sure.
B for better symptom management, usually rate control. And C for cardiovascular risk factor and comorbidity optimization. Thinking about it in that structured, often multidisciplinary way involving pharmacists, nurses, specialists seems to be linked to better outcomes, potentially lower mortality and fewer hospitalizations. Treat the whole picture.
Okay, this has been incredibly helpful, really clarifying the latest thinking. So for you listening, the big takeaways seem to be AF management is about the whole patient. It means aggressive stroke risk assessment with CHA2 DS2 VES-SC, prioritizing those safer, more convenient DOACs if starting anticoagulation.
Your patients.
Making smart choices about rate control drugs based squarely on whether heart failure is present.
Crucial distinction.
And maybe most importantly, doubling down on managing all those other health issues, the blood pressure, the diabetes, the weight. It's truly integrated.
Perfectly summarized. And maybe just one final thought to leave you with, something that really comes out of these guidelines. They strongly reinforce the need for antithrombotic treatment, usually anticoagulation, even in the very elderly, the frail, and even those who only have short, intermittent episodes of AF detected. The statistical benefit for stroke prevention is considered quite strong.
Okay.
But this really sharpens the clinical dilemma that doctors and patients face every single day. How do you truly weigh that statistical, often long-term benefit of preventing a possible future stroke against the very real, immediate, and sometimes catastrophic risk of causing a major bleed, especially a brain bleed?
Yeah.
Particularly as someone gets older, maybe their life expectancy is shorter. That risk-benefit calculation changes constantly. Does preventing a potential stroke 5 years from now outweigh the risk of a serious fall and bleed next week? There's no easy answer. It just underscores the need for really honest, ongoing conversations between clinicians and patients and constant vigilance. It's where the guidelines meet the complexities of real life.